for us. Then we'll be followed by Dr. Zita to do the theoretical part. Over to you, Dr.
Morning, everyone. I will be presenting here our case. It's a 24-year-old primigravida at 34 weeks and 6 days who present at 15 minutes to 1 a.m. with a history of having overdosed on an unknown number of white tablets. Take full history of her primary presenting complete.
Sandra, you had the story. So what would you like to know? So I'll just quickly check the patient's level of consciousness. So one, firstly, I want to know what time did she take these tablets? Is she the one who's using these tablets, or this tablet belong to someone else, like his mother or someone at home? And because they said they don't know what tablets are they. I think I would like to move on now to any symptoms that she has in terms of gastrointestinal symptoms, like is she having vomiting now? Is she having cramps? Any diarrhea? And also if she's having any other symptoms like dizziness or weakness, generalized symptoms. This should be the main issue around tablets. And then I want to know if there's any triggers now as to why at midnight would she present with she be ingesting these tablets. What's going on in terms of the social stressors? Is it something that provoked by relationships or what's going on, just to find out the trigger? And I want to know about any medical disorders, like probably is she suffering from depression or any psychiatric disorders, and any other medical disorders like HIV, which is common in our setting, and if she's taking ART. And then the pregnancy itself, I want to know if she has a patient. Yes, what? Stick to that. Stick to this story. Anything else? Anything else that we want to know? So we heard about is this your tablets, somebody's tablets, any trigger or anything like that? Do you want to know what a person will trigger overdose? Marlon back.
I think we covered most. I don't know if we covered how many. How many tablets did she take? Maybe an estimate.
And the family members, maybe even if they don't know what it is, do they have the box or the container that the tablets were in, so that we could figure it out? And she came at like 1:45 in the morning. Was it due to an onset of symptoms, or did she now disclose to the family that she's taken this medication? What made her come in the middle of the night? So that we know, and also the time, which Ms. Sonda was also already brought up.
If she vomited, Masoud inquired about vomiting. Did she vomit immediately? And maybe if some of the tablets did come out, or maybe she vomited after some time, maybe diarrhea.
There's the GIT symptoms that were asked.
The family gave her anything after they found out she took these tablets to try and reduce vomiting or try and reverse the effects of whatever they thought she took.
And as anybody asked about the exact time when she took the tablets, so I don't know whether I had it. Okay, and you don't want to know whether she's taking other substances.
Psych history.
Psych history.
Yeah.
I mean, a person could be on
being a non-use substance use.
Yeah. All right.
So she states that it was her pregnancy pills. She is unsure of the number of tablets taken, but thinks it may have been about 10. They were taken at 11 a.m. after fighting with partner. She was later on found by partner and her neighbor vomiting. She describes her vomit as to be brown in color. There was no hematemesis. Now she complains of abdominal pains and nausea. She reports to be feeling weak and also report reduced fetal movements. So in terms of her antenatal history, she booked at 16 weeks. She was I think they've covered.
Obstetric history.
As I go.
Oh, you wanted them to take an obstetric history? Yes.
So she booked at 16 weeks. She was RPR positive at booking, but there was no baseline titer done. She received 3 doses of bicycline, and the repeat RPR was negative. She's RH positive, RVD negative, and this was an unplanned but accepted pregnancy. She had a total of in terms of a gynae history, her last normal menstrual period was on the 1st of February 2025, and she wants implanon as a future contraception. She has no known comorbidities. She's not on any medication, and she has no known allergies. Basically, a surgical history, has no previous operations, and she used pre-pregnancy. She was using alcohol, but not in pregnancy, and she's not smoking. Outline your examination.
Here's the story. Okay. It's another patient for us.
So, the general appearance of the patient, and she was on the condition, acutely ill looking or chronically ill. Patient went to go to GCS. Is she awake? Is she confused? And how is she kept as well? And if I can smell anything since she took something, so I think if I can smell anything around the patient that might give the clues as to what she has ingested. And then I would want to know her vital signs, her blood pressure, her pulse, if she has tachycardia. I want to know her respiratory rate. And I would want to know her oxygen saturation as well. And bedside, I would want to know her glucose levels as well. And then on the CNS examination, I'll mention, and I'll go on. I would want to look for any pala, any bruises on the skin, and other bruises, any edema on the patient, and on CVS, I'll do the GCS as I've mentioned, and look for any focal neurological signs, and look at her pupils as well, whether they are dilated or constricted. And then I will go on to the chest examination, examine for CVS, any cardiac memos that she may have, S1, S2, palpates the pulse. And on chest examination, look for any signs of pulmonary edema. And abdomen reads the SFH to find out how far she is in the pregnancy, and auscultates the fetal heart if it's still present. Then I will also do a vaginal examination, look for any PV bleeding, because she also complained of reduced fetal movements as well.
What else did she complain about? She get it to be a vagina exam. She did complain of something.
Vomiting, abdominal pain as well.
Yes, so the abdominal pain. Vagina exam. Okay. Anything else anybody would want to find to general examination or whatever?
I believe drug marks, maybe.
Okay, although she says she doesn't take anything. Okay. Anything else? John this, yeah.
In the right house. different or hepatomegaly, and whether if you do is tender or not.
Hepatomegaly is what?
So if she took, she said pregnancy tablets.
11 in the morning.
So yeah,
Okay, but about midnight, the liver will swell so quickly.
okay.
What else? Eh? Sorry,
Tenderness.
tenderness, okay, anything else? I'm just looking for tremors, I don't know whether you mentioned tremors or not.
So her BP was 138/98. She had a heart rate of 96 and her sets were 98% on room air. Her GM was 0.6, and on general examination, she had no pallor, no jaundice, no edema, no tremor. On abdominal examination, her SFH was 33 centimeters. She was a longitudinal cephalic with no palpable contraction, and a cervical assessment also was closed. At CVS, she had normal heart sounds, and her chest was clear with good air entry bilaterally. From the CNS point of view, she had a GCS of 15/15. Pupils were equal and reactive to light, and there was no focal neurology. And CTG was done. I had a baseline heart rate of 135, and the CTG was otherwise assessed to be normal. So in summary, we have a 24-year-old primigravida. She's at 34 weeks and 6 days. She's RPR positive, successfully treated, now presenting with parasuicide and reduced fetal movement, currently having a hypoglycemic episode. What is your differential diagnosis or possible causes of overdose?
Yes, that's what. You heard the story.
Yes.
Okay.
So with the hypoglycemia, she might have taken an oral anti-diabetic medication that should be on the list. She might have.
By the way, did we mention that she said she took her own medication or what did you say?
Yeah.
Own medication.
Oh.
A pregnancy medication.
Own medication being the iron supplement. So it could be iron overload or iron, yeah. Those would be iron overdose.
What else? The paracetamol. She was getting paracetamol maybe for pain. Clinic it could cause hypoglycemia. Anything else? So you got iron, paracetamol, which is easily readily available. Anything else? Okay, let's go.
So again, yes, there was considered iron overdose, paracetamol overdose. We also considered any other substances, especially because she has a history of alcohol use. And then we said hypoglycemia. We queried the cause of the hypoglycemia. So outline your investigations and the reasons for those investigations.
Okay.
So I would want to do an arterial blood gas and just want to get an idea of her metabolic state. So whether she's acidotic, alkalotic, what her lactate levels are, a bicarb, a blood gas. So we'd also do an HB platelets, an NFT because we're concerned about paracetamol and iron ingestion. I would do
Exactly, and NFT are you looking for? What parameters are you looking for?
So you can get with paracetamol.
You want to know the total protein? No.
No, you
So what are you looking for? Tell me the parameters that you want to see.
your bilirubin, your ALT, your AST, because you could get a drug-induced liver injury, which would affect your liver enzymes. Mostly your ALT and AST.
You need both.
No, so you can do your ALT. And then I would also do iron levels and paracetamol levels because we're not sure which of these two agents you could have taken. I would do a UNE for her. And then those would be my serum blood or blood investigations.
Any other blood investigation or solo in this
Oh,
context?
INR, yeah.
I know now. And you should go to profile.
I would also try and get myself or someone available to contact Poison Center to see what the measures are if we're not sure what this patient has taken and what the options are, if there's something we need to do immediately. Or if we, like sometimes they'll give you steps on the immediate management.
It's an investigation. Come with management. Just right.
Okay, yeah, the urine dipstick. I would do an ultrasound to check the fetal condition. I would do and actually
Okay, they cover everything.
Yeah, and they cover. So here are your results then.
Some interpretation there. Tell us a little.
So this table is showing us the blood investigations done, I think, when around 2 days.
Some point out the abnormalities.
The abnormalities, yeah.
It's just stick to day one.
Day one. Our ISO count is slightly raised. One more in the platelet counts, iron levels are high. I think normal should be less than 60. So this is double the normal. Sodium, the electrolyte seems to be normal, and the renal function is also normal with the creatine of the life. And the liver enzymes, they are still normal on day one. They're slightly raised. Okay, the AST, I think it's double our reference laboratory range because it's use 40, so it's 80. It's double the reference range, it's high, but not that much. And the INR is also normal with sort of that. So then you know, the blood levels for paracetamol it's low. So this points towards more of iron overload is with a better levels there than 28. So it's not paracetamol therapy. The next day, the LT has increased quite significantly to 280. I don't have any INR there, but I think there's an element of liver failure that's going on.
Okay. So what is your immediate management?
Admit patient, preferably in a high care setting, full IV access and immediately correct the glucose. So give a bolus of 2% glucose, and then repeat the GM and see if it's going to come up, and then fluid resuscitation. So bolus with the liter. She was vomiting, so depending on the hydration status, and at this point, I won't know that really. So
You anyway, we're ready. But we're ready to you, did we not?
okay, so if she's still vomiting or nauseous, I'll give her IV Mazolone, and then contact poison center.
So when you say fluid, you just going to bolus. What do you mean bolus? Bolus is a jump. What do you mean? Are you going to have continuous fluid or just a bolus of fluid?
I'll start with the bolus.
How much?
1 liter, and then
You can give 1 liter as a bolus. Is that the correct terminology? 1 liter as a bolus, 90?
or you run it over an hour.
An hour.
So
She's in ketoacidosis that we need 9 liters in an hour.
Yeah.
So IV infusion, that's the IV infusion. So bolus is a big dose, big fluid that you give 500 mils is a bone challenge, whatever when you say bolus. All right, carry on, Manuel.
Okay, so if you're not alone, contact poison center for better advice in terms of what more I can do. But at this point, I will
Let's have
manage
some suggestions of what could be done
yeah.
while you're waiting for the poison center to respond, or what else could be done. potential aspects. So we're already aware that we're suspecting what overdosing. Iron. So what else could be done? So remember what time did she take the tablets? In the morning. She comes the next morning. Do we need to do anything or not? To say no, not this one. I won't do this. I will do this. I won't do this.
We can
We can.
We can do it a gastric lavage, but I think she has passed the window period for a gastric lavage.
What is the window period?
It means
What's the window period of the lavage?
I think it's 6 hours. from
Okay,
the-
so let's be committal. Okay. Anything else?
We need to shop for that. For
Activated charcoal is one of the medications that is used for overdose, but in the setting of the it's a little.
You don't think what?
The activated charcoal, I don't think it has a role in overdose.
In iron overdose. That's what you say. So you must be mention it and to obviously in the negative, so that it's clear that you are aware of its being used somewhere, whether it's appropriate or not. Anything else? Obviously, the iron now has been absorbed, and what have you not? And that's why we see high levels in the blood.
Yeah, I think modalities is also, but in this case, it's highly protein bound, so it's not that. One first, there has to be other indications of that. So, but that's just it's one of the things that maybe we can throw in there.
Anything else that can be done? A lot of iron now is going to damage the liver. It's already doing some bit of damage.
I remember that's what agent, but I can't remember the name.
What is the agent supposed to do? The one that you can't remember. All right, let's see.
So patient was admitted in high care. Like you guys had said, we seek for advice from Poison Center. They did say that the patient had passed the window period for gastric lavage and to give a deferoxamine 15 milligrams per kg per hour to correct obviously the hypoglycemia, and she was then started on intravenous fluid, which was the dextrose infusion, and we got an internal medicine review. She then had a CTG at 5 a.m. and this was the CTG.
Yes.
So it's a pathological CTG.
As evidence by
Surface it's by decelerations that are spontaneous and recurrent.
What
It
else?
usually go below 60.
Yeah, no, we hear the deceleration, repeated decelerations. What else on the CTGs? Reduced variability, yes. Okay, so what do you do?
His mom's stable.
Says what?
Mom, I just want to know his mom's stable at this point.
Yeah, she's talking to us.
Mom is stable. So, no IPI. Obviously it's not, and, planning a for an emergency. Cesarean section.
Let's see a plan. So we can say plan. What do you mean?
So, so IPI.
Yeah, I had the IPR. I just want to hear more. What's behind me? What?
Consent,
Yeah, let me hear about the consent. Let me hear about the consent.
So it's 34 weeks. It's got a bed within CTG. So a consent, the emergency cesarean section because the baby's heart rate is not beating well. And assuming that she's not in labor at this point, a cesarean section will be the quickest way to deliver a baby. However, I would still inform her that we are not certain or at this point in time, the fetal prognosis is guided and we will know
for sure at the time of delivery, but the pediatricians will be assure her that there will be theatre and the baby's condition will be assessed at the time.
Is the prognosis guarded or the word that you're going to use when it comes when it's married? Guarded.
Yeah. I'd be careful to say poor prognosis.
Manuel? Poor or better?
Looking at the CCG and the prognosis,
Remember when she came, the CTG was what?
what's normal?
Normal. She's not contracting.
Yeah.
So, and this is in the context of iron overdose. So what do you say to the patient? But it looks like here the doctor doesn't have courage and conviction to counsel the patient appropriately. And that's what happens often in the labor ward, especially in the context of abruptions. And we're rushing mothers to theaters because our story is not quite clear in our own head. What the story is. What do you say, Naidu?
There's a poor prognosis. We're trying to give the baby the best chance, but already this baby is being compromised. We don't know when it started because we don't know how long this has been the fetal condition. Because I'm not sure the timing of this trace. It's at night. So midnight. So it's been, the last trace was 5 hours ago. We're now concerned that the oxygen to baby is impaired. So we can't, I would say this is poor prognosis.
So what choice are you giving the mother?
We could give the mom, she's not yet in labor. So if we do not intervene and we do not take her for a Caesar, we cannot tell when she will deliver, and the prognosis will worsen. There's a chance she would end up with a stillbirth or an IUFD.
If we do a Caesar?
If we do a Caesar, there's a chance it will still be, the baby may not survive. It would be an FSB, or we just say pediatricians would be there, but there's still a chance baby may not survive, or baby may have poor outcomes in terms of possibly a CP. So baby, due to the lack of oxygen to the baby may have long-term effects. But there is also the small chance that baby will turn out well. We don't know, we can't tell for sure. But if she would have to make that choice, because most likely this is going to be a poor outcome, whether we wait or we're able.
If you have to say, doctor, you're the doctor now, can you advise?
I would
understand what you said.
I would advise her, because she's not in labor, I would advise the best chance we have of giving her a live baby is to take her to theatre. I would advise her to do a Caesar.
Sandra? Yes, same thing. So iron overdose, what does it do to the fetus? What happens to it?
It's the hypoglycemia that would impair or compromise the baby. Because with the iron overdose.
Hypoglycemia has been corrected when she came, just hypoglycemia. So without variability, we need to have the courage of a conclusion. If there's no variability and there's deceleration, it tells you that the heart is just being driven through the sinus action node. The higher centers are probably knocked off by now. And that's critical. The variability, if there was variability all along, there's no variability now. That's a more prognostic feature. Decreased variability with significant deceleration tells you there is definitely brain affectation. The cardiorespiratory center is completely knocked off here. And that's something that we need to begin to understand when it comes to CTGs. In terms of that, the others are just here and there. But if there was good variability, we know that the brain is functioning well. But there's no variability at all here. So you talk to the mother and say, we do something, especially in the context of abruption. That's why I'm just labeling the point to say, if we take you to Caesar, baby might come out alive, but with very poor brain function, or baby is going to be a stillborn. If we allow nature to take its course, we're probably going to end up with the same outcome, and the mother must make the decision. It must be clear what you are saying to the patient. All right, let's hurry on.
So patient was then counseled. She was booked for emergency Caesar for fetal distress. Decision to incision time was 45 minutes. We extracted a fresh stillborn. There was no retroplacental clots, and the hemostasis was achieved. Now these are bloods on day 3. What is your diagnosis?
Sunday.
So the renal function shows some worsening now. It's 30 minutes higher than 11. So it's actually grade 1. And then liver function test have worsened quite significantly. The transaminases are now 4,000 and less than 1 day. So by the end of June is still normal. INR is abnormal now, quadruplet now 2.4. And then there's a still, I think there's just ISQ. I don't change it in the last one.
It's still the same.
You know, the rest. But yeah, at this point, she's having liver failure, and evidenced by the high transaminases and the high INR. So she's coagulopathic now from the liver failure. So the other thing to check now is the sugar thing. Yeah. Yeah. That's so.
And the blood gas on the same class.
So the blood gas, she's not a acidotic patient, almost 3.4. I think it's fine. Not a bit fine.
Okay.
Yes.
So yes, she's got acute liver failure. So what is your management?
I do.
So we can continue, or if we haven't started already, the desfuroxamine. Try and counter the effects of the iron on the liver. Then start on anti-failure therapy for the liver, so lactulose, vitamin K, which would also help with the coagulopathy. She would need continued IV fluids. So because the GM went back to 3.6, so I think we would keep her on dextrosaline and adjust according and keep on GM monitoring to adjust the fluids according to her GM levels. Fluids, lactulose, vitamin K.
Where are you managing it?
And we're managing her, sorry, in a high care setting with the physicians on board. And her gas at this point is still normal, and she's not requiring dialysis based on that initial UNE. But we can discuss with ICU in view of that liver failure, because these patients can decompensate quickly. And just so that they are aware of the patient and they can give us some input whether or not she's a candidate or not. And then we would just need to do intensive fluid resus, continue to desfuroxamine until we see an improvement in the liver function, and do 48-hourly activities.
Okay, that's how you're running out of time.
So this was just a liver ultrasound that was done as well, which was otherwise normal. So yes, the patient was discussed with ICU. We gave FTPs. She was started on lactulose and vitamin K as well as thiamine, and she will continue to get the antidote deferoxamine, and she was getting the dextrose infusion as well. So the patient outcome, basically the liver enzymes eventually recovered. She was discharged from the physicians and was discharged home as well. She was reviewed by a social worker and psychologist, and we gave her a plan to follow up with us in local clinic in 1 week. Okay, thank you.
So we have to see such severe liver toxicity from iron, so we want to be educated this morning about this story and see how we do that.
And sorry, you didn't tell us about how, when and how the patient was delivered. You know,
No, just mentioned.
oh, it doesn't matter.
Share the secret and share this more.
Yeah, so we think the timing of delivery since she was 24 going forward, it was a similar case, and then we should try and deliver if let's say they presented 10 or after 34, it only could be the right thing to the same person.
No, I think obviously the only trigger here is that they did a CTG. and the CT was marked this repeated deceleration without variability. If the CT wasn't done, then the issue of whether we deliver or not would not have come into the equation, but they were looking after the mother and the baby as well as to whether they just prioritize the mother rather than looking at the baby because of the high overdose of iron that was showing just a trend towards significant liver damage. Whether that should have been the priority or not, it's obviously a debatable point, but obviously I think Zita would be talking to us whether we be monitoring or not monitoring when it comes to that. But I think the trigger was just the fact that CTG showed fast acceleration.
Good morning, everybody. So I'm Dr. Zita. I'll be covering the theoretical part of iron overdose in pregnancy. I will mention that this is quite a rare subject, and there's limited data in terms of this kind of a presentation. And we would suggest a dedicated Friday academic meeting to discuss this, because there's a lot of things. Yeah, as Unit 3. All right, without wasting time, ladies and gentlemen, we are past time. We're short of time, so we'll try and quickly go through. Okay, so firstly, here when we're talking about iron overdose, we're talking about a spectrum of clinical condition where there's a resulting excess accumulation of iron in the body. And in most cases, it usually involves children, but adults and pregnant women can be affected, especially because women in their pregnancy are exposed to supplements antenatally. So iron overdose is the second most common cause of acute poisoning in pregnancy, where paracetamol is the most common. But there is limited data, as I said, less than 100 reported cases of intentional iron overdose in the literature. It's often due to accidental or intentional, where there's a parasuicide or a suicidal attempt, where there's ingestion of these iron tablets. Although iron is essential, but it is easily accessible, and it's potentially toxic when in excess to both the mother and the fetus. In the mother, it can lead to serious maternal gastrointestinal effects and systemic toxicities, which we'll discuss in this talk. In the fetus, it can potentially cause premature birth, fetal demise, and cognitive and neurodevelopmental impairment, and even type 1 diabetes in the surviving fetus in the future. So regarding the types of iron overload, they are generally described as primary, secondary, or transfusional and acute iron overdose, with primary iron overload occurring in those patients with hemochromatosis due to low hepcidin, due to some genetic mutations in a gene called the HF gene. It's rare as well, 1 in 200. In terms of secondary or transfusional, these are patients who are receiving multiple transfusions, and they have a background of thalassemias or sickle cell anemias, certain malignancies. And remember that 1 unit of blood carries 20 to 250, 200 to 250 milligrams of iron, and they usually require like multiple, like as many as 1 or 2 transfusions every week or 2. And also in those patients with chronic kidney on dialysis, where the overload or intentional accidental overload. In pregnancy in particular, it's very rare. I mentioned that there's less than 100 reported cases, so it's something that is not quite common. Other contributors to iron overload include patients who have gestational alloimmune liver disease, alcohol-associated liver disease, chronic viral hepatitis, and metabolic dysfunction-associated steatotic liver disease. And it's mainly all associated with this hepcidin, where there's an impairment. We'll talk about hepcidin shortly in terms of the metabolism of iron. So when you look at the metabolism of iron, where do we get our iron? We get our iron from the diet mainly, and it comes either in a heme or a non-heme. So the heme is coming from your animal, sort of your meats, your liver, your fish, your poultry, and it's highly absorbed in the gut, absorbed like as is, it's not changed, and it's readily available for the body. But the non-heme coming from the vegetables and cereals is the non-heme one, and there's low absorption of that. In terms of the absorption, is absorbed in the duodenum by your enterocytes, and your non-heme ion has to be converted to from a ferric form to a ferrous form via the duodenal cytochrome B cells, and then absorbed by the DMT1 transporter. So only about 2 to 10% of this type of ion is absorbed in the gut, and the heme is 15 to 35% is absorbed directly unchanged by the heme transporter HCP1. It's then stored in the body in the form of ferritin, which is a protein made locally by the cells to store it for safe use, because if it's not stored in this way, then it reacts with hydrogen peroxide and forms radicals, which we'll see shortly. It's mainly, you mainly will find it in the liver, the macrophages, the bone marrow, even the spleen, and temporarily it will be stored in the gut enterocytes until it's sloughed off, and then there'll be a new layer there that will form. It's exported to the plasma by ferroportin, and then you have enzymes called hepastine and ceruloplasmin, which will then convert the ferrous ion, which has been absorbed, into a ferric ion again, so that it can be attached to transferrin and transported in the bloodstream, then to the bone marrow and liver and elsewhere as hollow transferrin. Hepcidin is responsible for regulating the release of ion by basically ferroportin. So your hepcidin is a hormone produced by your liver, which acts as a gatekeeper. So it is increased in situations like ion overload, so that it limits the absorption and release of ion, and it's decreased in cases of like ion deficiency and naturally in pregnancy, so that there's enhanced absorption and release of iron because there's increased demand in pregnancy. It's utilized in terms of forming your hemoglobin for oxygen transport, myoglobin, energy production, the mitochondria, formation of cytochrome, enzymes, gene regulations. Even the immune system uses the iron, which we will not get into, and also it's used in hematopoiesis in the bone marrow. The macrophages then recycle the iron from all red blood cells, and if there's excess ferritin, transferrin, then it will be in the form, no, not ferritin, but ferritin will be then is an insoluble form of ferritin, is called hemosiderin. So that is like a degraded form of ferritin in the lysozymes, and the excretion. Iron is not actively excreted from the body. It doesn't have a mechanism to excrete that. So it stays once it's absorbed and recycled. So the balance is controlled by absorption and not actually excretion. But you do have a loss of 1 milligram per day through a cell turnover, like in the gut, the skin, the bile, and menstruation, etc. But it's negligible. It's just 1 milligram per day. But 95% of your iron comes from the recycling of the iron that you already have in your body. This is just a diagrammatic representation of what we just spoke about. As you can see there, the duodenum, you have your heme there. I won't go through all of that again, but this is just a diagrammatic representation. So what happens in the case of toxicity? So the body cannot directly excrete, as we've said, the iron. It's usually always bound to a carrier molecule, and hence excess can lead to unbound free iron, which will then cause the toxicity. So when the iron comes in excess, then it bypasses the absorption regulation by hepcidin, and the actual iron directly causes corrosive injury to your gut, basically. And when it gets in intracellularly and it's deposited in the sort of packaged form, then it will react with hydrogen peroxide and form reactive oxygen species through a reaction called the Fenton reaction. Then these free radicals cause oxidative stress and lipid peroxidation. They then disrupt the membranes of structures and cause necrosis and cause vessels to be leaky. And then this results in damage of the respective organ systems, including the liver, heart, brain, and endocrine system. It will also cause mitochondrial dysfunction and lead to metabolic acidosis, direct poisoning to the mitochondria. It will also attack the B cells of the pancreas, and it leads to what we call the bronze diabetes, where you have this hyperpigmentation of the skin associated with the diabetes later on. You will also have a coagulopathy from the liver injury and cirrhosis later on. And iron also crosses the placenta and causes toxicity, similar toxicity to the fetus. So now I want to look at the daily requirements of iron. So if you look there, wait, where's my pointer? Let me just turn on the pointer. There's a pointer there. So as you can see, in terms of our national guidelines, they recommend 60 milligrams of elemental iron for our pregnant women. The non-pregnant women just require about 18 to 27 milligrams per day. And if you have iron deficiency that is confirmed, then you're required to have a higher dose of 100 to 200 milligrams per day divided in 1 or 2 doses. And even in the postpartum period, you continue with this for up to 3 months until your hemoglobin gets above.
After it's important because we often don't emphasize that the patient was iron deficient, she was treated, just go through for 3 months after the normalization of the hemoglobin. If you don't do that, then you don't restore the iron stores. That's a critical point.
Yes. So you continue that even up to 3 months after. So Marisa is emphasizing. So now, having looked at those requirements, now let's look at the supplements that we commonly have available. As you can see, most of them have about 50 milligrams upwards, with some of them like Chelapreg and these drugs having about 15, 12 milligrams. But our generic ferrous sulfate that we use for our patients has 65 milligrams of elemental iron per 200 milligram of this film-coated tablet. So now, keeping that in mind, remember that in your IV preparations and your transfusions, you have about 200 milligrams of iron per these sort of blood products, as you can see there. So having that in mind, you will see that to get to your toxic levels, you start off at around 20 to 60 milligrams per kg to start to get this mild or moderate toxicity. So if you take a 70 kg odd patient and basically then you start to calculate now, 20 per kg for a 70 kg, that's 1,400. From that going upwards, then you start having some symptoms, which is equivalent to about 21 tablets. And a pack has about 30 odd tablets that we give the patients. And remember, these patients, we give them as many as 6 months supply, even at other facilities. And especially if they're iron deficient and we're treating them, we give them more. If you get to the 120 upper limit there, where you have potential fatal effects, that if you calculate a 70 kg lady there, it gets to 8,400, which is about 129 tablets. So that is like four packs worth of iron, and the patients easily will have that kind of an access. So this is just to show how easy it is for patients to actually get access to this toxic causing tablets. Okay, now I will move on to our management principles. So when the patient comes in with this iron overload, our principles are: we stabilize the patient, we want to assess the toxicity, prevent absorption, chelate the iron, and then support the organs and the fetus. So initially, when they come in, just make sure that you stabilize them, do your ABCs, stop the vitamin C's and supplements, and
CAB this moment.
CAB, sorry, yes. And you give your intravenous infusion. These are patients which needs to be managed in an ICU or high care setting with a multidisciplinary team, which would include toxicology, hematology, and internal medicine. Even surgeons will need to be involved. Remember, your vitamin K and FDP we'll discuss later for your coagulopathy, and to correct the acidosis, support them with the oxygen, cardiac monitoring, and monitor their GMs. So now, looking quickly at the history, I want to ask them about the time and amount of ingestion, the number, the types of tablets, the milligrams, the formation. What type of formation? Is it ferrous or fumarate? Are there any co-ingestions, ingestants such as vitamins or drugs, alcohol, corrosives? What Was there an intentional overdose or was it just accidental? Is there social stressors? What is the timeline of the symptoms in terms of the vomiting, abdominal pain, hematemesis, which they will usually present with? Is there previous anemia that was treated? Are they known with hemochromatosis? And then you assess the obstetric issues, the gestational age, other fetal movements, contractions, and you assess the vaginal examination as well. Then on your examination, you will check your vital signs, check for tachycardia, hypotension. Is there pallor, jaundice, or that bronze skin appearance, which we described earlier? The abdomen, is it tender? Is there hepatomegaly? What are the bowel sounds? The CNS, do they have an encephalopathy? And you check your cardiovascular system, and you also check your fundal height, your fetal height, and are there any signs of hepatic failure, including flapping tremors, which is hysterexis, jaundice, confusion, and fetal hepaticus. So then you investigate the patient. You want to do a FBC check. What's the HB? These patients might be bleeding or in shock. Do they have a kidney injury? Check your LFTs. Usually they are well above 1,000 and they are markedly and sharply elevated. And the bilirubin is also elevated in the case of hepatocellular injury. Assess coagulopathy, which usually arises from the hepatic failure. Assess acidosis, which is usually a severe high anion gap metabolic acidosis, which is usually above 12. So the actual cutoff, it depends on how you calculate it. So you get your cations and your anions, you add them together, and then those amounts you subtract, and then you calculate what is the anion gap. Usually around 12, 8 to 12 if you're not accounting for the potassium. But if you add the potassium there, then it's a 12 to 16. So anything above 12 to 16 if you use the potassium, or anything above 12 if you didn't use the potassium, then would be a high anion gap metabolic acidosis. Anything above 30 would be a severe high anion gap metabolic acidosis, and that would be one of the indicators for possible iron overdose as a cause. Then you check your serum iron. Usually you expect a peak 4 to 6 hours after ingestion. And if you get a level which is more than 63 millimoles per liter, then that would be a sign of your moderate to severe toxicity. And if it's more than 90, then it would be severe and life-threatening. And I believe this patient had 128, so they were in the severe life-threatening range. Then you have your total iron binding capacity and your transferrin saturation of if the iron is more than the total iron binding capacity, then that means there's a lot of free circulating iron, and this is a big indication for using your defuroxamine, which we will discuss just now. Check your blood glucose for hypoglycemia. In terms of imaging, your abdominal films will show your radiopaque appearance in terms of your iron tablets if it's within a certain time, which I will show you just now a picture, and it will tell you about the pill burden and guide on whether or not you need to do whole bile irrigation. Your ultrasound you can do to assess your fetus for viability, and check the maternal liver if you have any concerns. And then if your facility has, you can use what we call liver iron concentration using an MRI, a T2 MRI, and it will actually tell you, without doing a biopsy, how much iron is actually concentrated in the liver. And it's safe in pregnancy to do that if you have those facilities. The obstetric monitoring constitutes a CTG. If viable, they suggest that you do a continuous CTG after you've stabilized the patient, not while you are stabilizing the patient. You consider growth scans when you're following up the patient after the patient is recovered, and you will continue with serial monitoring of your LFTs and ABGs and your ferritin. And you'll also check your urine as well, your urine output. So now this is a picture of an abdominal film showing you these bright circular opacities, which is also known as the tablet storm. And basically within 4 to 6 hours, that is when it's best and easily visualized in the stomach. But after that, then they get absorbed and then you won't be able to see something. So now I need to note here that the appearance or lack of this and the number does not correlate to the severity. So that needs to be clear. Then in terms of your iron studies, here I've just got what happens in the typical pregnancy and what is suggestive of acute iron overload in pregnancy. So if you look at your ferritin, levels above 200 in any trimester is unusual and you must be suspicious of those. But above 300 micrograms, which is 60 millimoles per liter, is strongly suggestive of overload. And then above 1,000 is definitely even associated with high risk of organ dysfunction. Then you look at your transferrin saturation. In pregnancy, you're expecting it to be about 15 to 35%, but in iron overload, it would be well above 45 to 50%. And then if you look at your serum iron, should be between 40 to 120. And if you have high serum iron associated with high transferrin saturation, this will be your support for a diagnosis of iron overload. And then your total iron binding capacity and your transferrin, as you can see there, should be 350 to 500. And if you have high serum iron and a high or normal total iron binding capacity, then this would be the cause for your the total the transferrin saturation, total saturation of transferrin there. And you can look at your CRP as well, which will be elevated and can inflate the ferritin without a real overload. So you have to consider that as well. You then stage your patient. Wait, where's the stage? Okay, there it is. So you have stage 1 through 5, where stage 1 occurs in under 6 hours, where you just have the GI irritation, the nausea and vomiting, abdominal pain, and hematemesis. These just require supportive care. Then stage 2, you have increased capillary permeability, hypotension, and the patient then suddenly appears to look like they are recovering. And this is a false assurance because iron is still actually being absorbed and causing issues. Then you move to stage 3, which occurs in up to 3 days, where then you start having the hepatic, the renal, the cardiac failure, the shock, the acidosis. And here is where your acylation usually is indicated. And then stage 4 usually requires ICU and with your deferoxamine, your chelation agents. And the prognosis here usually starts to become poor. And then stage 5, which occurs weeks later, will be as a result of gastric scarring, and you might have gastric outlet obstruction, and these might need surgical intervention. So you need to watch out for that for those patients. Your differential diagnosis would include sepsis, acute fatty liver, HELLP syndrome, and other metallic toxicities. But to differentiate clearly, once again, in iron overload, they will have extremely high ferritin, which is above 1,000, with the transferrin saturation above 50%, and severe and early hegma above 30 to 40 due to mitochondrial poisoning. And the other conditions will have low or normal transferrin saturation despite elevated ferritin, and only a mild hegma, which is below 30. So that is how you would try and differentiate, because some of the issues would overlap. So how do you prevent absorption through GI decontamination? So you don't need to do GI decontamination if the patient is asymptomatic and more than 6 hours after the ingestion, or if they're under 6 hours, but the levels are less than 20 milligrams in total elemental iron. But if they are symptomatic and the levels are above 20 milligrams per kg or above 400 micrograms per deciliter, then you can consider gastric lavage or whole bowel irrigation. But the gastric lavage usually is effective if the patient presents under an hour. So you basically use an oral gastric tube. You insert it directly into the gut, and then you first aspirate, and you take the aspirate for toxicology, and then you then infuse 300 to 400 mils of saline, and then you extract that, and then infuse again, extract until the contents are clear. Whole bowel irrigation with polyethylene glycol electrolyte can be used as well as a 1.5 to 2 liter per hour, basically, where you are literally flushing out the gut until the contents that are coming from underneath are clear. So activated charcoal is ineffective, as mentioned earlier. And bicarbonate is not used since it causes systemic toxicity. Then there are other things like syrup of ipecac induced vomiting. Some people, they think that if they induce that vomiting, that it works, but it doesn't really. It's not really favored or recommended. Other sources talk about therapeutic phlebotomy, but usually that's reserved for those patients with hemochromatosis and not usually for acute iron overload. In terms of your chelation therapy, your triggers would be a serum iron above 90 millimoles per liter. The iron should be drawn within 4 to 6 hours, even if symptoms are not severe. But if you have that level, then you give the chelation therapy. If your serum levels are between 60 and 90, and they're associated with severe GI symptoms of hypotension, metabolic acidosis, then you give the chelation therapy. When you don't have iron levels available, or they are delayed, but there's clinical evidence of severe toxicity, then you can still give the chelation therapy until you get your iron levels. Or if there's radiographic evidence of large tablet burden with systemic toxicity. So even without your iron levels, in that case, you will give your chelation therapy. So your chelation therapy would be your deferoxamine. So chelation literally means to close. So deferoxamine basically it acts as an attachment for your iron, so that it's excreted in the urine. It just binds to the iron. So you give it as an IV, 15 milligram per kg per hour, with a maximum dose of not more than 6 grams per day. It's usually given IV. There are IM and subcutaneous and oral forms, but they are generally avoided in pregnancy because you can't control the absorption and the half-life. But the IV preparation, because it's an IV infusion, you can control and stop whenever there's adverse effects. So the evidence says that you do not withhold in pregnancy on the basis of the theoretical fetal risk. The drug is not associated with human malformation and doesn't cross the placenta. So that is what they say about these drugs. And as I mentioned, that the oral forms are generally documented as contraindicated for pregnancy. So it's just that IV form that they allow. And how it works, it removes intracellular iron and iron from ferritin and hemosiderin, but it spares the iron in the cytochrome and hemoglobin. And it is then excreted renally after metabolized by the plasma enzymes. Your urine will generally look vein rose like red during the therapy. So like that wine there, it will look something like that. Okay, so practically now at the bedside, how would you calculate? So the one vial of deferoxamine has 500 milligrams. Then you take that and you constitute it into 5 mils of sterile water, because it's a powder form, and then it gives you 100 milligrams per mil. And now in your patient with acute overload, you want to now do your IV infusion. So you take that diluted portion and you add it to either normal saline or Ringer's lactate or dextrose water. And you can use anything between 100 and 215 mils. So just note that you are never allowed to do an IV push of this. You have to always calculate you have to always do an infusion. And basically, they recommend that you create a 1 to 8 milligram per mil solution by adding that this to that basically. And you initially start off at about 15 mils per kg per hour. and you don't want to exceed 24 hours of this without involving a toxicologist, because not many people have experience with this. So as soon as you have to get to above 24 hours, you need to have somebody who's experienced to start intervening. So you stopped when your serum iron is less than 60 micromoles per liter, and your symptoms improve. We've said the max doses. So now this is just a practical example. So if you have a 70 kg, then that is 1050 milligrams per hour. Then you put 2 grams in 250, you have an 8 milligram per ml solution, and that means you need 8.
That's fine.
Yeah. Okay. All right, so I've made the point there. So you always use a dedicated line, and you hold off if there's sepsis or of siderophilic organisms. So there are certain organisms which are attracted to iron and use iron. If you confirm that in, say, a urine MCNS, then you have to hold off, because they will use that iron that is excreted renally. You monitor your blood pressures every 15 minutes, check the color, check your UNEs, your LFTs, INR every 8 to 12 hours, monitor the eyes, and you monitor for adverse events, which would include injection site pain, nausea and vomiting, headache, dizziness. Your urine will be orange to red color, so don't be alarmed with that. And then you will have some serious and rare complications from deferoxamine, include ocular ototoxicity, infections with this Yersinia sepsis, which is a siderophore, which I mentioned uses iron. So you need to treat that first, and you can have acute respiratory, adult respiratory distress syndrome if you give a rapid transfusion. Renal and hepatic injury, thrombocytopenia. So animal studies in terms of the fetus and the effect of the deferoxamine show skeletal and ossification abnormalities, but in human studies, there's limited evidence, actually no evidence really. So I will move on because of time. This is just to show how do we support the liver failure. So you need ICU support. Okay, I won't really dwell on that because of time. You know how to manage a liver failure patient. Okay. Okay, here I just added the liver transplant indications. There's a King's College criteria if you are in a facility which has that. So it's if it's non-acetyl, okay, because you don't have liver. Okay, maternal stabilization takes priority. And remember, delivery does not reverse this acute liver injury. In terms of your fetus now, there is limited evidence about how and when to monitor, but generally the evidence says stabilize the mother. That is your focus. Once the mother is stable, the delivery will not reverse what has happened. That is the basic thing that they say in the literature. So you stabilize the mother, and then you monitor your fetus. And then remember that the acidosis is caused by the maternal acidosis and uteroplacental perfusion compromise. So once you correct that, then it will hopefully. And then remember to give your steroids, and you deliver only if the mother is unstable, or if the CTG is abnormal despite an optimized maternal status. That is when then you would deliver, but not in any other scenario. The follow-up, psychological support, monitor your LFTs, monitor your renal, and watch for gastric outlet obstruction. Your prognosis is generally good if you are treated early. But if the patient come in late, they usually have these complications, including hypothyroidism, hypogonadism, hepatocellular carcinoma, diabetes mellitus type 1, and then there's high risk of mortality if the patient comes in with shock and hepatic failure. And you need to also remember about prevention. So you educate your patients antenatally, you screen them for depression or suicidal intent and pre-existing conditions which require repeated transfusion, and set them patients in view of the easily available iron supplementation antenatally. It has the potential for serious fetal and maternal morbidity. There is limited experience with chelation therapy in the maternity guidelines and national guidelines, and no clear protocols for management of these patients. However, if you do the right tests for the right patients, institute the right intervention, and you stabilize the mother fast, and you do evidence-based contamination and selective chelation and a coordinated care, then you will hopefully get the right outcomes for all the affected patients. And remember to educate patients on for those at risk of intentional overdose and screen them and prevent this kind of a thing from occurring in the first place. Okay, thank you.
Thank you, Dr. Zita and Dr. Khumalo. I don't think we have time for questions unless there's something burning.
So the initial question by Dr. Noda, if I understand correctly, saying that you don't have to waste visa or clear patients on the basis of their term in the I think that there should be, in case there's compromise at a later stage. Because once you start operating, for example, this patient, we need to DIC, I think, once you've operated as well and the DIC wasn't more problem so far. So I think eventually just to resuscitate the mother first, correct, stabilize the mom, the baby may end up being resuscitated as well during the process. Take in terms of delivery.
So the issue is that iron overload is not an indication for delivery. Delivery will be due to obstetric reasons. I think that's the bottom line. And the delivery was done for obstetric reasons, which was a CTG, not because she had iron overload. So I think that deals with that aspect.
Last question, Makwa.
But maybe on the same point, I think what we could have done differently if we knew better, so we continue CTG, then those changes would have been picked up there. There would have been still a certification to that. So, as I understand, the arm was not unstable.
Yeah, just a follow up. Patient was asked for those ones. So continuous CTG for 4 to 5 days was not practical. But I still think if you get to a severe range of the iron level, more than 90, we already know the effects on the features, hypoxia, acidosis, and all these things. So I think the mother could be given an option to say, you are well over the 4. The mobility or the affectation of the fetus is not very predictable. It doesn't matter how many times you do the CTG. Well, now you are stable. And then one of the considerations could be delivered. I think that's what I made out of this treatment.
Okay. Thank you, everybody. Have a good day.
Yeah.